Welcome to the BioBalance Healthcast, episode 681. Why interpreting your own labs can be dangerous to your health.
BioBalance Healthcast features conversations about anti-aging medicine. Your host is Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging. Dr. Maupin is the author of The Secret Female Hormone, the seminal work about testosterone replacement therapy for women, and Got Testosterone, the award-winning book for men that helps men choose the most effective and safe form of testosterone replacement. These books are available on Amazon or from Dr. Maupin's office at BioBalance Health in St. Louis and in Kansas City. Dr. Maupin's office is currently accepting new patients.
Welcome to the BioBalance Healthcast. I'm Dr. Kathy Maupin of BioBalance Health, and I'm going to talk to you about something that has just started happening in the last 6 months to a year, but has been more and more frequently a point of problems for my patients. This is a governmental rule that requires all lab companies that draw your blood to send you the results immediately upon completion. So this rule would send you, like, if I ordered a panel of 18 tests, and every time a test was finished, it will ding on your phone and tell you to go look at your lab work. That's irritating, and I've had a lot of patients complain about that, but that's not the worst part of this. What happens is even if you get all of your lab work at once, you look at it with a layperson's eye. Even if you're a doctor and you don't do the type of medicine that is being tested, you won't know what that test really means to you, because all you have is a reference range, something that they consider, the lab considers normal or average for somebody who's getting their blood drawn. But remember, they don't tell you what it really means to you, because all they ask you is your age and your sex. So they have gender and they have age. They don't ask, like for women, they don't say, hey, did you have a hysterectomy and have your ovaries out when you were 35? Do you have, and that actually is very significant to interpreting hormone tests. They don't say, are you in menopause yet? Because that's important to interpreting your H&H, your blood count. They judge, for instance, every woman is given a range of hemoglobin and hematocrit that is based on a woman who is having periods and bleeding. Now, that's well and good unless you're on the pill and you don't bleed, you're on the IUD and you don't bleed, or you're menopausal and you don't bleed. Then what happens is we have a lower range, so they don't diagnose, say, anemia as early for somebody like us, because basically if somebody's bleeding, they are going to have a low level of iron. But if you're not bleeding and you have a low level of iron, say you are a man, they would be sending you to have your GI tract investigated, because usually if you're anemic and you're eating iron-containing foods, the problem is usually loss of blood, and usually that's in the GI tract. So you would miss a diagnosis that way, or you would scare a woman saying she had too high a blood count when she stops bleeding. So when we stop bleeding, our normal H&H goes up to what men have. Basically, we don't lose iron, so our H&H can be the same level as theirs, and it's different. A man's, just for instance, if I can get this to be nice to me. The normal hemoglobin for a woman is about 11.6. I just lost one of my references here. So because of that, men's are like 12.6. So there's a range in there where a man would be considered anemic, but a woman would be considered normal, even if she wasn't having periods anymore. So they don't ask us enough questions to actually give you the interpretation for a layperson to read your lab and know whether you're normal or not. This kind of rule was drawn up by people who aren't doctors and who are probably politicians, and they're answering some patient who never got their blood work or couldn't get it from their doctor. So everybody is being punished by getting this, and then either I have people come in and go, oh yeah, I looked at my blood work and I look great. They're not great, because in their situation with their problems and their particular hormones or no hormones, they may not be great, but they think they're fine. What that might do, some people will just say, I'm canceling my appointment, I'm fine. Okay, that means that you're going to miss a whole lot of things that a doctor wouldn't have missed. And that's one way to err. The other way to err is one that I've heard quite a bit lately, and that is, I'm so scared. I got my blood work back and my, say, total cholesterol was so high, I'm afraid I'm going to have a heart attack. So I have a 45-year-old person in front of me who's not going to have a heart attack, who thinks because her total cholesterol was high that she's in trouble. Well, first of all, total cholesterol for women is not very reliable. Women, the cholesterol test was developed for men, and we aren't men, and women have a lot more of the good cholesterol, HDL, in general, or the majority of us have a lot more HDL than men have. So when you have a test that was made for a different gender, and you're trying to judge yourself by that, you can get scared because men don't have as high a total cholesterol and be healthy. Women have this HDL, and they add the good cholesterol plus the bad cholesterol to get to the total cholesterol. That doesn't make any sense to me. I don't know who developed that process, because if you're looking at women who usually have a variation of high HDLs, our total cholesterol can look really high, and our LDL can be in the basement, which is healthy, and we're fine. We're not collecting plaque. We're not making arteriosclerosis. We have no reason to worry if we have that situation. I would interpret it for a patient, reassuring her that this is not a sign of needing a statin or being in any danger. But when they look at it, all they see is high reference range cholesterol. They don't know about HDL or LDL, and they're afraid. And they may be afraid for a week or so or more before they come in to see me, so I can explain every test. In general, that's what's wrong with politicians making rules for specialty services that they don't understand. And this should not be the case, but it is. So now we have to live with it. So, let me get rid of this. Okay. Now, one of the things they could do is they could improve their program so that they took your age, your sex, your stage for women, stage of whether you're fertile, if you're on birth control, if something that's going to change your hormones. They could ask all of those questions, put it into a computer, and then be able to use variable ranges for these certain circumstances. But then again, there are other things that we look at as physicians. We look at physical signs. We ask symptoms. We have to use other pieces of information to actually interpret this lab. It's not just the lab and that's it, and that's how you tell what's going on with you. I mean, that's why we go to medical school, and that's why we continue education to remember what we learned in medical school, or what we just learned is different now than it was in medical school. So anxiety is a huge issue, or misinterpreting your lab because it is based on a different group of people or a different age group, gender or age group, but it's not obvious within the information that you're given by the lab how to interpret it or how to change your interpretation. So in general, what this means is reference ranges make assumptions. They make assumptions about how old you are, and they know how old you are, but where are you in aging? Some people at 70 are completely healthy. Some people at 70 are completely old. That's part of what the doctor talks to you with you in mind and all your other medical history in mind, not just a test. It doesn't just stand alone. Oftentimes we're ordering tests to see progress for people. So what we want to see is, are you getting better? Not just diagnosis and is your treatment adequate, but are you getting better? We need to hear from you to correlate that with your lab test. So when you get your blood work, I guess the one thing I'd really like to state is don't stress out until you get to your doctors and make your doctor tell you what all those mean, especially the things that you're worried about. Now, we do that all the time. That's how we approach lab work, is we tell you the good and the bad of every lab that you had ordered and we have results for. And we adjust it or make it appropriate to you and your circumstances or situation. So this may seem nebulous, so let me just give you an example. Example of any woman who's 45 years old and over gets an FSH or LH test. Now, these are two tests of a pituitary hormone, two hormones that manage, when we're young, they manage our periods and our fertility and our ovulation. And they work together, they go up and down, and they basically will be high at ovulation for just maybe a day or less, and then they drop. So when we order these two tests, we need to know, is the patient premenopausal? Now, premenopausal would mean that their FSH and LH could be anything on a given day. They could be different levels, and they change over time within a cycle. So we use this information for infertility. We use it to see if there are enough eggs left, or we used to do that. We now have another test for that. But when we order the test, if the patient's less than 45, they do look at this range to see, is it too high? Sometimes it looks like ovulation, or is it premature menopause? That's something that's going to have to take a doctor to look at, because if the estrogen, a different test, completely different test, is very, very low and the FSH is very, very high, it's possible that that's menopause, or it's the beginning of menopause. So you have to know the situation. Now, what the lab does is everybody over 45, they assume they're menopausal. And so if the FSH and LH are sky high, they consider it normal reference range. Okay. When you're menopausal and you have an FSH, so normal is less than 23. You have an FSH of 75. What that parallels is symptoms that you have that are hot flashes, night sweats, insomnia, inability to think, irritability, depression. All of those things can go along with a very high FSH and LH. But they say, no matter how high it is, unless it's extreme, that's in the reference range for somebody over 45. They don't even say that. They just say it's in the reference range. So people look at that and say, well, I'm fine. I'm in the reference range. Well, you have 6 or 7 symptoms related to low estrogen and high FSH and LH. You're not fine. So that reference range doesn't mean you're well. When it says you're in the range, it just means, yeah, you're menopausal. Other things that can change this, your FSH and LH, if you're on a birth control pill, should be suppressed to less than 0.5. They can't measure it. Those two hormones should be dropped to the lowest level to prevent ovulation. So, if I'm looking at this test and I'm trying to see if the pill is strong enough for somebody, I look for a suppressed FSH and LH, well below 23, and LH well below 10. So you have to see my purpose for this one same test is completely different for these different patients. And it takes knowing why I ordered the test, and also what situation the patient is in for me to actually interpret it properly. The reference range doesn't do it. Lastly, we often use this test to see if a patient has enough estrogen. Last week, the British Journal of Endocrinology came out with a study that showed that when women wear patches for their estradiol, their blood level of estrogen isn't high enough, and their FSH and LH aren't suppressed. What that means is, if you put a patch on, you still may have hot flashes, you still may have night sweats and all the other symptoms of menopause, or some of them. Menopause means low estrogen. Or sometimes it just depends on the person and the time of year, and there's a lot of variables about how you absorb your estrogen. But they found that it didn't last the length of days they said it would last. Like, if it's supposed to last a week, it would last 6 days. If it was supposed to last 3.5, it would last 3 in many people, so they'd have to increase the dose. Well, there is no higher dose than a 0.1 patch. So they found that to be inadequate. They'd have to go off-label and use more than one patch to get a person's FSH and LH down and their estradiol up so that all their symptoms were treated. I realize this is complicated, but this is just one single test. Two particular hormones that can be used for a variety of reasons. And if you just look at it and you have terrible symptoms and it tells you you're normal, you're not going to believe yourself about your own symptoms. You're not going to trust your own observation of your own body. And that's what women have been doing for years. We don't want to continue to do this. That's what got us into the kind of a second-class citizen role. We've been told we're fine when we're not. And then because we're told we're fine, we think we're imagining it. So that's what I'm trying to dispel. And what we just got from the government was yet another rule that is interfering with people's medical care. Yes, you should have the results of your tests. No, you shouldn't have to interpret themselves. You interpret them yourself, and you should have your doctor interpret them with you. Now, granted, there are some primary doctors that just order a blood count. Now, what do you know from a blood count? What do you know if somebody's anemic? But if you don't know if they're menopausal or not, you don't know which normal you should use, and they just give the normal for cycling women. So I have to adjust it on everybody who's menopausal. But on a blood count, we also look at white counts, and white counts before menopause should be normal. After menopause, as we age, then our white count drops, and that means our immunity is getting worse. We are not as immune competent. That's one of the things that I see in low testosterone people. So I look for that in the white count. Are they really low? Do they need help with their immune system? And testosterone should bring the white count up. So that's something I look for. Nobody else who does other kinds of medicine necessarily will do that because they don't have testosterone as a treatment. So that's the application of the blood tests and interpretation that has to be done by a physician. There are other reasons we have problems with interpreting the lab tests. One is the reference ranges are often absolutely wrong. They're a throwback to 20 years ago and they haven't changed them. One of the examples for this is a fasting insulin. So fasting insulin should be less than 10 according to a huge nationwide study 15 years ago. And that's the number that people doing research on insulin resistance use. But the number on Quest and LabCorp and the other big labs is you have to be under 18 on the insulin test, not under 10, to be normal. So I'm always saying, yeah, this looks normal, but it's not normal, and you have other signs of insulin resistance, like not being able to lose weight, your fasting blood sugar is high, and or sometimes you actually have prediabetes. So there are other tests I do to determine if someone is pre-diabetic or insulin resistant or diabetic. But this is one of those tests that may look normal, and then people say, oh, there's nothing wrong with me. Well, they have the wrong normal. They've adjusted it everywhere except on their lab. Now, that's a problem. That's a problem for me in trying to explain what I'm doing and why I'm treating somebody with metformin who has an insulin of 12. It's over 10. It's keeping her from losing weight. I treat her with metformin, but it isn't classically insulin resistance because they haven't updated their normals. I find that to be a problem for me. So another lab that does this, just for example, is homocysteine. Homocysteine is a test that actually can help diagnose MTHFR gene deficit, which causes emboli. Not necessarily blood clots, but emboli, pieces of soft plaque that break off and become a stroke or a heart attack or a pulmonary embolism. People who have high homocysteine are at risk for that, but the number that they give for high homocysteine it doesn't mark who's at risk for this. It marks when you're really in trouble, 10.4. But normal is 8 and below. So I'm diagnosing somebody before the lab would diagnose them because I don't want to wait till they get really bad and may have a stroke or a heart attack from this. So you can see the problem with having the reference ranges wrong. So in terms of that, the labs, I am going to have to separate this lecture talk into 2 talks, and I will be giving you the rest of the reasons that you can't read your own lab and interpret it properly next week. I will be giving you other examples of what's wrong with the system and what's wrong with the reference ranges and how we can fix that. So please join me next week, and we'll have the rest of the story.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth.